So first I'd like to thank everybody for being here tonight and taking a little bit of your time to join us and have us, present some educational material for you all. My name is Dan Schwartzbauer. I know a lot of you in here, but for those of you that I have not met or do not know, I'm one of the founders and partners and president of Simulate Technologies. This is an exciting day for us as we continue kind of on our mission to provide affordable weight-bearing CT images to as many people as we can. Tonight, we're going to support this educational event in parallel with that mission. Knowing that, I guess, initial education and ongoing education is pivotal in understanding, diagnosing, and treating disease and deformity in foot and ankle surgery. Tonight's webinar will be the first of 4 webinars that we will organize and support in 2024. All of those will be centered purely around education of weight-bearing CT and its value that it presents to us. For a little housekeeping note, there should be a chat section in the bottom of everybody's screen to enter any questions as the webinar goes on and as the session goes on. Please enter your questions in that section. I will keep track of those. We will have a question and answer session at the end, and we'll get to all of those. This session will also be recorded and eventually loaded onto the Simulate Technologies website, which will be www.simulatetech.com, so that anybody can access it at a later date. And finally, so we can move on to the presentation, I'd like to introduce our host this evening, Constantine Demetracopoulos. With his credentials and background, we're thrilled to have him sharing his experience with weight-bearing CT and specifically applications of weight-bearing CT in foot and ankle surgery. So I'm going to pass off my rights here to him, and Dr. D, hopefully you will have the ability here to share. The last piece of this is if everybody could just keep their microphones on mute throughout the presentation so everybody can hear Dr. D clearly, then again, we'll get to all of the questions at the end. All right. And again, bear with us here as there we go, we got it.
All right. Well, yeah, thank you, Dan, and sorry for the delay. I'll catch up, I promise. We'll end on time, whatever that means. But thanks for having me, and thanks for those that have logged in to hear this. I wanted to give sort of my perspective on the use of this technology, weight-bearing CT in general, in my practice and how I use it and how it's helped me, and to show some cases and hopefully spark some interest and discussion. I do have disclosures and relevant to this talk as well for Simulate. So if you really think about imaging and the history of imaging, weight-bearing CT has sort of come about in recent years, and it has become more and more something that we're talking about and more something that we're using with increasing frequency. And if you look back all the way to X-rays, it's not too dissimilar, because you can imagine that X-rays didn't always exist. We treated patients before X-rays, and much of that was through our physical exam and our observation. And plain radiographs first discovered, in 1895. And the first X-ray machine was purchased only a couple of years later by Pennsylvania Hospital. But it wasn't, immediate adoption, and it wasn't immediate success. And it took time. And even though there was obvious benefit and obvious interest and reason to be using it, it certainly took a good number of years, almost 30 years, for it to become the standard of care. And so maybe we're facing something very similar when it comes to this new way of obtaining a more advanced imaging, or obtaining a weight-bearing CT scan. So why did X-ray not take off right away? Well, anytime there's new technology, there's skeptics, there's cost, um, there's lack of access, and people don't really know what to do with it or how to use it. And I think this is hopefully part of the purpose of today's discussion is for me to show you how I use it and what some of the benefits may be. Um, when you look at research, it's certainly taken off in the last 4 or 5 years. And more research is being done with weight-bearing CT for us to better understand different pathologies in foot and ankle. Um, but I don't want this to be too research heavy because I think a lot of times when you read the papers and you're reading different things about angles and measurements and coverage maps, and you don't really know how to apply that in your clinical practice. And so it doesn't seem obvious as to how will this technology really benefit me and my patients. But where can we learn most from weight-bearing CT? Well, the three categories that I use it most frequently are hallux valgus deformities, bunion patients, progressive collapsing foot deformity, or patients that are particularly going to undergo surgery for surgical planning. I'll show you cases of that. And in my patients with ankle arthritis, less common, and that's maybe just simply the reflection of my practice is cavo varus deformities, where I'm reconstructing a flexible or a rigid cavo varus deformity. Midfoot arthritis, when I'm deciding which joints to fuse. Am I going to fuse 1, 2, 3 tarsal metatarsal joints? Am I going to fuse an navicular-cuneiform joint? How do I make that decision? Where is the deformity, particularly when they have loss of their arch through the midfoot? Where am I fusing and how am I going to do that? And especially for our Charcot patients, because then really we're looking at a complex deformity and how are we going to correct it to give patients a plantar grade foot. You can also use it in trauma, and I do a little bit less of this, even more so in terms of the subtle Lisfranc injury. Is there some subtle diastasis that needs to be stabilized? The subtle syndesmotic injury, or somebody who's had a syndesmotic injury and has persistent pain after surgery, and you want to compare to the contralateral side. Is the syndesmosis wide? Is there some subtle diastasis that is placing an increased strain on the ankle that can benefit from a revision operation? It also allows us to better assess certain pathologies, and this is across different patient categories or issues. So you can really look at a bony impingement when patients are applying a load through the ankle and foot. You can see how the bones are interacting with each other. So is there impingement in the subtalar joint, in the subfibular region? Is there impingement in ankle replacement in the gutters? Again, we can look at ligament stability. I just mentioned Lisfranc widening. You can compare it to the contralateral side. Syndesmotic injuries, midfoot collapse. You can look at the subtalar stability in a patient with a flat foot deformity. Is there instability at the subtalar joint that needs to be stabilized with an arthrodesis? You're getting a better sense of alignment. Not only alignment in what we conceptualize as the AP and the lateral, but you're looking at rotational malalignment and deformity. And again, you're able to assess arthritic changes in a more detailed way compared to plain radiographs. So how do I use it in my hallux valgus patients? Well, I tried to get this for every patient before surgery. Now, I must admit, I don't get it for absolutely every patient because that may not be practical, but I really do it particularly in patients who may have some arthritis at the articulation between the metatarsal head and the sesamoid. And what I'm really looking at is to see how much rotational deformity do I have in the metatarsal, and to what degree are the sesamoids matching the deformity of the metatarsal head, and to what degree they're subluxated. And that can then help me determine how aggressive I'm going to be with my lateral soft tissue release, how much rotational deformity do I need to really correct when I'm correcting the hallux valgus deformity. And then you can obtain a scan down the road, whether it's 3 months or 6 months, to assess your correction, to assess your healing, and certainly to problem solve for patients that are having persistent pain. And I'll show you a case of that a little bit later. But what we do know, and this is research done by my colleagues, Dr. Conti and Dr. Ellis, that really looked at first metatarsal pronation and how that correlates with recurrence and with outcomes. And the patients who had correction of their pronation, so they had less pronation. Now, they didn't have supination. You know, we always want to be perfect, but ultimately, if you can improve the pronation or decrease it, patients had better outcomes than those who it wasn't corrected at all, or frankly, for those that the deformity actually worsened, which you can imagine can happen. And recurrence rates were lower in those patients who had improved pronation after their bunion operation. And here you can see that when compared to before surgery and after surgery, you've corrected the sesamoid position, you've corrected the rotation of the metatarsal head, and you can see a significant difference in the physical function PROMIS scores in this patient cohort. Now, what about flat foot? I do get it before surgery on patients, and I'm really looking at the subtalar joint, and I'm looking at the medial column. And I really want to identify if the subtalar joint is unstable, if the subtalar joint needs to be fused as part of the flat foot correction or not. And I'm assessing my medial column. Do I need to do a first tarsal metatarsal arthrodesis? Is a sag really happening through the navicular-cuneiform joint? And how am I going to manage that patient? And again, I can consider getting these images down the road 3 to 6 months later to assess how I've done in my alignment correction, to assess if things have healed, and again, to troubleshoot patients who are having pain. And again, I'll show you a case that went well and a case that didn't go well. But why is this important? Well, we do know that the subtalar joint is critically important in patients with a progressive collapsing foot deformity, and that really the key is to look at the middle facet. And subluxation of the middle facet is the most sensitive measure of peritatal subluxation in these patients. And so when you have uncoverage of the middle facet greater than, let's say, 18%, that is very much predictive of patients who are symptomatic at a stage 2 flat foot deformity. And this is more so than when you compare it to the posterior facet. And so you'll see middle facet subluxation before you see it in the posterior facet. And so this is the first place you want to look to see what's happening to the subtalar joint, what's happening to the foot. And again, this doesn't mean that all patients with some subluxation of the middle facet need to have a subtalar arthrodesis, but potentially the severity of that subluxation may guide your surgical decision-making. Now, what about an ankle arthritis? And I must admit, this is the majority of what I do. And this is the majority of my patients who have weight-bearing CT. How do I utilize it in these patients? Well, frankly, every patient with ankle arthritis who's undergoing surgery will have a weight-bearing CT image. For me, it's to look at the preoperative bone quality. That includes subchondral cysts, that includes sclerosis, because a post-traumatic bone that's hard doesn't heal very well. It's to look at the deformity in the ankle. Where is the erosion in the plafond? Is to look at the foot deformity and determine or start to plan in my mind, what do I need to do to correct the foot underneath the ankle? And particularly if I want to utilize patient-specific guides, a weight-bearing CT image is critically important to be able to plan the surgery accurately. Post-operatively, historically, we've done it for patients who are having pain and looking at complications, whether it's a fracture or impingement or cysts or loosening, assessing healing of the implant, or in patients where we may not have adequately corrected the deformity. But recently, we have started a prospective study looking at about 150 patients who were obtaining images, weight-bearing CTs on every single patient at 6 months. And we really want to study how alignment both of the ankle in rotation, alignment of the foot in 3 dimensions can affect our outcomes. Now we know from patient-specific guides, and this is research that we did some time ago and others have replicated, and it's always good when you see multiple studies showing something similar, is that ultimately patient-specific instruments are more efficient. They save time, actual time. They utilize less fluoroscopy. And accuracy is certainly similar when compared to standard instruments and high volume users. And that's a good thing because not everybody has the luxury to do many ankle replacements per year. And so if you have fewer cases in your practice, you can achieve excellent alignment by using this type of technology. But one critical question that we have, and Andy Goldberg has done some good research on this, is looking at the rotation, right? And how do we decide what the correct rotation is? How do we know where the implant should be pointing? Does it follow the ankle? Does it follow the foot? How does that change in patients with a cavo-varus deformity? And how does that change in patients with a flat foot deformity? And so rotation seems to be a tricky thing. Most of us utilize the gutter bisection versus the medial gutter. I can't tell you one person is more right than the other, but I can tell you that those are different values. So you can also split the difference. You can try to follow the foot and follow the second metatarsal, but again, that won't work on every single patient. And so ultimately, rotation is a tricky decision to make when performing an ankle replacement. And I would argue that it's one of the critical places where you need a weight-bearing CT technology. Why is that? Because when somebody is standing or when someone's applying load onto their foot, as you'll see with this technology up against a foot plate, you're guaranteeing, as best as you can, certainly, that the foot is in a plantar-grade position. And then you can not only better understand the deformity, but the position of the talus is reliable. That's true in the sagittal plane, like I'm showing you here, and this is a simulate image with the patient pressing against the foot plate. And you can see here that you can see exactly where to set the talus in terms of dorsiflexion or plantar flexion. We know that if you dorsiflex the talus, you're going to put more stress on the implant bone interface in the posterior portion of the talus. And that can be problematic. It can lead to talar fracture, talar subsidence. But also when you are loading the foot and when you're in a plantar grade position, you're going to be able to better determine the rotation of the talus. And that makes planning a lot easier. Clearly, if you have this image on the left, it is much harder to plan where to put your implant than if you have the image on the right. And ultimately, the better job you can do before surgery to plan how you're going to do the replacement, the better outcome you're going to have. And so here's a case. This is a clubfoot patient. And clubfoot patients have unique rotational challenges because they tend to be extraordinarily externally rotated. It's just a challenge to do the surgery. This patient has a previous arthrodesis, so it makes it, again, even more challenging. And so I utilized a patient-specific guide to perform the surgery, and I was able to plan out the alignment, both on the sagittal plane, as you see on the bottom right, as well as the rotation on the upper left. And then I was able to take that, and on the left, you see here the planned surgery. In the middle, you see the intraoperative image, and on the right, you see the postoperative image. And I'm able to replicate my plan during surgery and at my final follow-up because I have the right information to feed that plan. And that's where weight-bearing CT is critically important in your planning. Here you can see an amortis. On the left is the plan, in the middle is during the surgery, and on the right is after the surgery. Now, this is a study that I did, and I really shouldn't say I did. This is a study that Caesar did when he was a fellow at HSS. And he said, well, what if we look at the foot and ankle offset? Now, the foot and ankle offset is a three-dimensional measure of foot alignment underneath an ankle. And he said, well, what if we were to measure this? Does that predict your decision-making during surgery in terms of deformity correction? And what we found out was that it absolutely did. And so subsequent to that, the International Weight-Bearing CT Society did another study, and they said that the foot and ankle offset, again, a three-dimensional measure of foot alignment underneath the ankle, correlated with periprosthetic cysts. And that's also important because that also means that the degree to which you correct the foot underneath the ankle matters in terms of the ability for that load to be evenly distributed at the bone metal interface, may affect polyethylene wear and osteolysis. And again, as this study showed, the development of periprosthetic cysts. And so now we're doing a study, a prospective study, as I mentioned, and we're going to look at the foot and ankle offset after surgery and determine how well we're correcting patients, and does that alignment then correlate with outcomes. So let's go through some cases. Here's a bunion patient on the left, and here's the bunion patient after surgery. And as you guys imagine, then usually when we do these talks, we show you our best cases. And this is a case I think I did a pretty good job. I reduced the intermetatarsal angle. I reduced the sesamoids. I did an Aiken osteotomy as well. And here you can see my pre-op CT demonstrating the amount of rotational deformity I have in the metatarsal head, as well as the amount of subluxation of the sesamoids, and then how I can correct that at the time of surgery and get the sesamoids reduced. And what you'll see is that the rotational deformity is modest. And I think that in most cases, it can be overstated how much supination, or I'm sorry, how much pronation patients truly have. And so in my experience looking at these before surgery and after, it doesn't take a lot of rotational correction to correct these patients and correct this deformity. Okay, so I promised you I would show you some bad cases because everybody finds those more interesting. So this is a case that the surgery went well. Well, what about this case? So here's a patient with a hallux valgus deformity, not a terrible intermetatarsal angle. You see the sesamoid position there. You see the lateral. Okay, I know how to do this. I can do this. I'm going to use a similar technique, just like I did on the last case. And then you see that image on the left. And you walk into the room hoping the patient's going to say everything's fine, nothing hurts, but that's not true. Patient's having pain. So pain at the first metatarsal phalangeal joint. And you can see at that image, you see that the metatarsal head, that articular surface, is almost pointing laterally, right? It almost looks like a patient with an increased distal metatarsal articular angle. And so you think back and you go, well, maybe that's what the problem is. But then others will say that the distal metatarsal articular angle is really a misinterpretation of rotational deformity. Maybe it's really a pronated metatarsal head that makes it look like there's an increased distal metatarsal articular angle. So it's all over the place. So what's the better way to assess this? How do I determine what I'm going to do during surgery? Well, I'm going to get a weight-bearing image. And so here you can see this is the patient's CT. And when you compare the metatarsal head to the floor, to the weight-bearing floor, you say, well, the rotational deformity is corrected. That's not supinated. It's not pronated. It's in a fine position. But what's not okay, what's not correct are the sesamoids. The sesamoids are not where they're supposed to be. So you go back to the image and you say, well, how am I going to fix this? And certainly there's more than one way to do it. And I am no expert in hallux varus. But what I chose to do was to do a reverse scarf osteotomy and tried to bring the head over medially and also derotate it to correct the distal metatarsal articular angle. And thankfully, and again, we'll never show you a bad case that ends up bad. We'll show you a bad case that we can somehow pull together. Thankfully, this patient did well. All right. So what about this patient? This is a case courtesy of Dr. Ellis, so thank you for that. This is a patient with a progressive collapsing foot deformity. And you can see that the patient has the typical findings, as you would imagine: abduction at the talonavicular joint. There's some plantar flexion of the talus. There's valgus in the hindfoot. And you can see that the lateral process of the talus has completely slid forward and is impinging upon the anterior process of the calcaneus. This is really an unstable talus with regards to the calcaneus. This is where the talus has not only translated anteriorly, it's internally rotated. It's starting to fall off of the calcaneus. And so we're going to address this and we're going to stabilize this. And so in this case, even though the patient's flexible, even though this is a flexible deformity, we're going to utilize an arthrodesis to correct the deformity and stabilize the foot. And here you can see a talonavicular and subtalar arthrodesis combined with a medializing calcaneal osteotomy and a first tarsal metatarsal arthrodesis to stabilize the foot and correct the alignment. All right, so Dr. Ellis did a great job with this case. I'll show you my case. Here's a patient who has a flexible foot, has a collapsing foot deformity. You see plantar flexion of the talus. You see some abduction deformity. And I get my weight-bearing CT. And I look at this, and this is only one image. I'll give you that. But when I look at the middle facet, I think to myself, well, it's not subluxated so badly, and I probably don't need to fuse a subtalar joint. This is a young patient. He's in his early 40s. So let's see if we can save it. Let's see if we can reconstruct the foot with the surgeries that we know how to do and not fuse a subtalar joint. And so I did the surgery that I'm sure some of you still do, hopefully, but I did a medializing calcaneal osteotomy, lateral column lengthening, not too much, a cotton osteotomy. And when you look at the lateral, you think to yourself, well, it doesn't look like I did anything. I mean, it looks like I just put some hardware on the foot and the foot's still flat. And 6 months later, 9 months later, the patient's having lateral hindfoot pain. So it doesn't look like I did a very good job at all. Now, his medial pain is better. So that's one piece of good news. But he's having lateral pain. So what's the first thing to do? Well, the first thing is to say, did the lateral column lengthening heal? Because we know it doesn't always heal. Well, how do we assess that? We're going to get a CAT scan. So here's the CAT scan, shows that the lateral column lengthening healed. So at least I managed to do that right. What about the middle facet? Well, look at that middle facet. That looks a lot subluxated, especially when I compare it to my preoperative image. So what may have happened? What could have happened? Well, when you look at that little box down below, and I don't know if you guys can see that, but that box down in the bottom right, you can see that the patient's not quite standing on their foot. They're kind of leaning backwards. Their ankle's a little bit plantar flexed. And maybe they're not putting all of their weight on their foot. And so that can be deceiving, and that could be tricky. And maybe that's the problem. Maybe I caused the instability with the surgery. Who knows? But certainly you can see here that there's a difference. You can see in the subtalar joint that there's more subluxation. There's some impingement there laterally. And ultimately, this patient is likely to undergo a subtalar arthrodesis. Hasn't chosen to do it yet, so we'll see if we can postpone it, or maybe he'll improve over some more time. But that's the discussion I've had with him, is to go back and perform a subtalar arthrodesis. All right, now here's an ankle arthritis patient. This is a little bit more in my wheelhouse, so I'll show you this case. Now you can see in the tibia, there's a lucency, right? You don't think much of it when you look at the AP, and you certainly don't think much of it on the lateral. You see some reactive changes, so maybe it's a chronic, maybe it's a stress fracture. Well, what are we going to do with this, or what do we make of this problem? Well, when you look at the CT image, and again, it's important that it's weight-bearing. You can see that the medial shoulder of the talus is pushing into that defect, right? And why is that important? Well, that may affect your decision-making of whether you're going to do all of this at once or staged. So let's say I decided that this is too much, and I'm going to do this in two parts. I'm going to bone graft and fix this chronic stress fracture, and then I'm going to come back and do my ankle replacement. Well, what's the likelihood of that being successful if the talus is going to be pushing into this chronic defect? It may not heal. It may lead to more failure. And you look at on the axial view and you say, well, I see where that fracture is, but maybe I have enough enough tibia to actually get an implant to work. And so in this case, I did this as one stage. And you can see here, I cheated the tibia and a little bit of valgus. We'll say I did that intentionally. Maybe, maybe not. But you can see here that I've placed my ankle replacement. I have bone grafted the anterior distal tibia with bone that I removed with my tibial cut. And I've been able to place a plate and screws to secure the bone. And this patient had the normal recovery as any other ankle replacement and thankfully has done well. Now, bone quality is a theme. Here's another patient with significant cystic change on the tibia, but most so on the talus. And you can see here a very large defect in the talar body. And why is it important that this is weight bearing? Because I'm planning where the implant's going to go. When I make my cut, I can visualize that angle of the cut, how much bone I'm going to remove, how much bone will I need to bone graft that cyst. Again, you can do this with patient-specific instrumentation, or you can do this with standard instruments, but you need to have these relationships set so you can better understand the problem, better understand the deformity. And I was so focused on bone grafting the talus and so focused on not damaging the talus that I realized halfway into the case that I had actually fractured the tibia. And so that can also happen. And I'm sure some of you have had this happen in your practice. But when that happens, it's okay. It's just like our last patient. We can plate the tibia, still finish bone grafting or talus, and use an implant that will allow that bone graft to consolidate. And we can achieve fixation in a more anterior part of the talus where the bone is healthier. All right. Here's a more extreme case. Now, here's a patient that has a pilon fracture, underwent an extensive surgery. And we know from these images that the bone in the distal tibia is going to be a challenge. Now, this patient had a staged approach. So the first operation was to remove the hardware because no matter the quality of the CT scan, it's very difficult to see underneath all this metal to see what the bone looks like. And so I'll play these videos for you, and hopefully it doesn't take too long. But what I'm really looking at is to see, what does the bone look like in the distal tibia? Can I do a replacement in this patient, or can I do a fusion? And for the people that say, well, maybe just do a fusion, maybe that's just easier. Well, I still have to deal with this very large defect. And what's better? Is it better to fill a defect with metal, or is it better to fill a defect with a piece of cadaver bone or a big cage? So these are the considerations. And again, it's so much easier to visualize and conceptualize and plan this when the images are in a weight-bearing position. If the foot's plantar flex internally rotated, it's very difficult to see this. So this is the CT scan, and I can use an augmented implant with a large base plate to fill a lot of this defect. And I can still use a stem to achieve fixation and use a standard talar component. And I can do a replacement in this patient, again, because I can better understand the deformity ahead of time. I can better plan my surgery. And again, I can do this by looking at the images and preparing for surgery, but you can also do this using patient-specific instrumentation. But having the right information is key to make these decisions. Now, what about deformity correction? Now, you look at this patient, and they have a varus deformity, but I would argue they have an even more complex foot deformity. And this is somebody that had had a previous arthrodesis of their foot. And you can see that they are very much overcorrected in varus and fixed supination. And this comes up a lot, you know, and people talk about, well, how do you tackle big deformities? What's a deformity that's too big? Is it a one stage or a two stage? And I'll briefly just take the time here. As you see, you're looking at a coronal CT image that is weight bearing. And again, as I'm looking at these images, I'm thinking about the foot. I'm planning my surgery as to how I'm going to correct this deformity. But ultimately, there's no right or wrong answer. Whether you do something as one stage or two stage, ultimately, the goal is to correct the alignment. The goal is to alleviate pain and improve function for your patient. And so there's no right or wrong answer. In this case, I chose to do this as two stages. I was more comfortable with that. And again, there's nothing wrong with that. And in some cases, as we know, It takes more than 2 stages because maybe one of them is not successful. Okay, so how did I tackle this problem? As you can see here that the ankle deformity is in varus. You see but the varus in the ankle certainly doesn't match the severity of the supination deformity that exists between the through the talonavicular and calcaneocuboid joints. So, and then this is the sagittal, just to highlight the fact that this foot's really not plantigrade. I mean, this is how the patient stands, and this is how she walked in. And this has been a chronic problem for her. And you can see here just how supinated, how much weight she's really bearing on her fifth metatarsal. All right, so what are we going to do about this? Well, this is a technique that Dr. Haddad's spoken about many times, where we're going to realign the ankle and just hold it there. Just hold it there just long enough so that we can reconstruct the foot, get the foot to heal, and then come back and do a successful ankle replacement. And so I correct the varus in the ankle. I can cut through the foot and correct the foot alignment with a midfoot osteotomy. And here you see that. The subtalar joint, or the calcaneus, came nicely with the talus. And so at the initial surgery, I did not do anything to the calcaneus or the subtalar joint. Everything was through the transverse tarsal joints. And I allowed it to heal. And this is at around 6 months. Now, one thing you'll notice is this little periosteal reaction. And so I did have another CT scan, and I saw that the patient was getting a periosteal reaction in the medial distal tibia. So again, that informed me of how to do the next surgery, where when I did the ankle replacement, I placed 2 screws in the medial malleolus to better protect that bone. Again, it was a stress reaction. There was no fracture line, and you can see the cortical thickening, the periosteal reaction there to really strengthen that bone. And when I'm in there and I'm looking at the ankle, I thought, well, maybe I should just add a little bit of a lateralizing calcaneal osteotomy. Why not? Why not give myself a little bit of backup so that I can get a little bit better hindfoot alignment? And here you can see the lateralizing calcaneal osteotomy that was done with a minimally invasive approach. Again, this patient has many, many incisions on her ankle and foot, so we want to minimize the soft tissue trauma. And here you can see the AP of the foot. She also developed, you see there are some metatarsal stress fractures during this big staged reconstruction. Here's her before, and here's her after. And again, before on the lateral, and here's the after. And again, this surgery is possible because I can plan. I can look at the deformity. I can look at it with a CT scan. I can visualize it in 3 dimensions. And then I'm able to plan the surgery, what actually needs to be corrected, and each step that we need to take to correct this. Here's another interesting deformity, because here you see varus in the ankle, and you see that the talus is really internally rotated and uncovered by the navicular. And so it's almost a combined deformity of a varus ankle that's unstable with a plantar flexed talus. And you can imagine that if you were to just rest the implant on the talus back there, that's just not going to be successful. So to some degree, we have to rebuild the foot to allow us to replace this person's ankle. And then when you look at the varus in the ankle and the severity of that deformity, but you look at the hindfoot alignment view, it almost seems like the deformity evens itself out. And what you really have is you have a varus ankle and you have a valgus hindfoot. And here, again, with a weight-bearing image, you can see that there's the talar head, internally rotated. You can see the medial gutter arthritis and the medial translation of the talus. So we know that this patient is going to have a lot of lateral ankle instability and has a lot of bone-on-bone arthritis in the subtalar joint as you scroll into the subtalar joint right there. Okay, so how am I going to address this, right? And this is an older patient. This patient was in their late 70s. And again, that's going to be part of the consideration. They're older. Maybe 2 surgeries is not practical for them. They have a good body weight. They don't have other comorbidities. And so maybe this is a case where we can push the envelope and do this as 1 surgery, a little bit different than the case I showed you earlier. And so here I'm realigning the foot and I'm pinning it provisionally. and I'm going to then proceed and do the replacement. I have to release the deltoid, right, which makes no sense in some ways when you're correcting a valgus hindfoot, but I'm going to release the deltoid. I'm going to make my cuts and place my talus where it belongs on the talar implant where it belongs on the talus, right? So not with the talus plantar flex, but in a corrected position. And then I'm going to do a brostrum to reestablish the lateral ligaments and stabilize the joint. And with the ankle prosthesis in place, then I'm going to proceed and complete the surgery and fix the hindfoot. And there you can see the fixation with the hardware. And here it is post-op. And surprisingly, the medial column was stable enough that this foot is plantigrade, it's balanced, and the patient did not require any additional procedures as of yet. Again, an older patient, a little bit lower demand, and it makes sense in some cases to push the envelope and do things as one surgery. Now, what about this patient? This patient came to me and said, well, I'm here for a right ankle replacement. I said, okay, well, you're right. Your ankle doesn't look like most people's ankles. It's a little unusual, so let's investigate a little further. Here's your hindfoot alignment view. It looks a little bit valgus. There's the lateral, and it looks like there's some anterior impingement. So I guess we could do an ankle replacement. But here's the weight-bearing CT image, or this is one of the simulate weight-bearing CT images. And what do you see here? Here you're seeing that there's a lot of instability in the subtalar joint. We talk about subfibular impingement as something that can happen, and most of us think that it's more of a soft tissue thing. But no, this person truly has subfibular impingement, and they have subtalar impingement, and they have an unstable subtalar joint. And so when you look at the AP, you go, well, gosh, I wonder if I can alleviate that anterior impingement by just fusing the subtalar joint and not having to do an ankle replacement. Wouldn't that be better for her, at least for the time being? And so that's what I did. I did a subtalar arthrodesis with a medializing calcaneal osteotomy. I utilized an allograft bone to try to prop up the talus as much as I could. And I also, you can see there, a cotton osteotomy for the medial column and medializing the calcaneus with a minimally invasive osteotomy. And there you can see these are her, I believe, about 6-month x-rays. So she's still early on. We'll see. But here you can see that the bone is healing, in the process of healing. Screws are in a good position. Anterior impingement is better. And we're going to follow her and see how she does. And ultimately, my hope is that we can delay, maybe avoid, or most likely delay an ankle replacement until down the road. All right, well, they don't all work out great. So here's a patient. Again, I said I was going to show you some failures. And here's a patient who's 57, had an ankle arthrodesis. And you can imagine from the hardware that the ankle arthrodesis was not his first surgery. He'd had many surgeries prior to that. And he comes in really complaining of talonavicular pain. And I thought, well, maybe what we can do is we can give you an ankle replacement and fuse a talonavicular joint at the same time. Wouldn't that be great? Wouldn't that give you better function given you're a younger age and he's sort of an active person? So I did the ankle replacement. I did the talonavicular arthrodesis. And 9 months later, he says to me, I feel just as bad as I did the day I met you. I am no better. And I look at his x-rays and I think, well, gosh, that doesn't look so bad. I mean, why is he in so much pain? And it's hard to tell, and it's not clear. And so I'm going to get a CT scan to really assess, does this patient have gutter impingement? Or does this patient have a talonavicular non-union? So here you can see this is a simulate CT. And clearly you can see there the medial gutter. And there's some impingement, right? And we know, many of us know, that often impingement hurts just as bad as the arthritis. Impingement can be very painful. And then I look at my talonavicular joint and I realize, well, thank goodness, at least that healed. So what am I going to do for him? Well, I'm going to do a gutter debridement. And again, I can make that decision based on the CT images, and I don't have to do anything to the talonavicular joint. So I've been talking a lot about weight-bearing CT, and I've showed you a lot of cases, and I've showed you images. And many of you are familiar with a curved beam image, and that's a company that make this device. It's a cone beam technology. The patient stands, and you can get weight-bearing CT images. And again, as I said to you, many of the images that you've seen today are with this machine, and we have one of these machines at our main hospital in the city at HSS. But what is this other technology? And some of the images are that I showed you today are simulate CT images. And this is a device that you can see there on the bottom right, where patients can sit and they can press up against a foot pedal. And it can be calibrated, so patients are pressing at half their body weight. And the foot pedal has some technology built into it so that patients have to press evenly against the pedal, otherwise it will not depress. So instead of cheating on the heel or cheating on the side or maybe a little bit more on the ball of the foot or in an uneven way, patients have to press evenly on their foot against the pedal so that the pedal will depress and then they will register that load. And the best part of this is that it can be used with regular CT machines. And so half the patients that I see now, as my practice has progressed, are outside the city. I see patients in a satellite location, and I'm sure many of you do too, where you don't see all your patients in one place. And so it's not practical for me to have two of the big machines because, frankly, I would never be able to convince them to purchase a second one. But I can use this technology, and I can use the standard CT, and I can get weight-bearing CT images. Now, many people will say, well, is it really weight-bearing? Is it really the same? How does it compare? And I'll give you my take on it. Now, curved beam is certainly first to market. They have a lot of the computational software. They have a lot of the research. And if you're lucky enough to have one, you can bill for it in your practice. And it's what's been available for many years now. But what are some of the negatives? Well, it costs a lot of money, so there is a barrier to obtaining one, and that limits access. I will say that when I'm looking for bone implant healing, so if I'm concerned about a lucency or cyst, if I want to know really how well did the bone heal to my tibia, or is my talus subsiding, the metal artifact reduction is not as good as a standard CT, which makes sense, right? I mean, CTs are pretty good at suppressing that metal artifact, and the image is not as good with a curved beam. Now, what about simulate CT? Well, it's much less expensive. I mean, it's a tenth of the cost of a curved beam, and therefore it's more accessible. As I mentioned, the images can be better because you're using a standard CT scan. And you can have some confidence that patients are pressing a certain amount of weight on that foot plate, right? Because you can control that. You can guide them through the tech, obviously. Will make sure that they're pressing against the foot plate a certain amount, and again, that they're pressing evenly against the foot plate. Well, what are some of the negatives? Well, there's no fancy software that goes with it, right? You're going to view these images the same way you view any CT scan that you order in your practice now, in your standard viewer, and it's limited to foot and ankle. Now you can do some knee images, and it can go up to the knee. It can go and it can include all the protocols for patient-specific instrumentation. But it certainly doesn't go to the hip like some of the newer curved beam models. And in this study, this was published by Steve Conti's group in Pittsburgh, who have done a lot of the work to develop this technology. This was a study of 12 normal patients. Okay, these are volunteers. So this study has not been replicated yet in patients with pathology. But as you can imagine, it's difficult to replicate this study. These are patients who volunteered to have 3 CT scans. They volunteered to have a CT being non-weight bearing, so no pressure at all on their foot. having a CT pressing against the foot plate, and a standard, what you can conceive of as a cone beam, curve beam, standard weight-bearing CT. And what you can see is a similar pattern where when patients are applying weight to their foot through the pedal, or patients are standing, you can see different values that reflect weight bearing compared to a non-weight bearing CT. And even in some of the cases where the pedal, where you're pressing against the pedal, the pedal weight bearing was different. It's probably not really clinically different. And what you're really seeing here is a pattern where pressing against the foot plate, pedal weight bearing, simulated weight bearing does show the foot in a weight bearing position. And again, this is one study, but there have been other studies using this technology published in the development of this product. So what is the summary? Well, weight bearing CT is a proven technology. It's been around for some time. And I do believe it's changing how we understand and treat our patients. And the hope is that this will allow us to provide better outcomes for our patients. Access has been a challenge. We've been some of the most fortunate to have this technology early on, and we've used it for many years. But as we expand, or at least as my practice expanded to a satellite location, I needed to have access for my patients there, and I was able to achieve that with a Simulate CT. So thank you. Hopefully we have a little bit of time for questions. Any comments?